In the previous videos, we discussed that if we diagnose a patient with chronic heart failure with reduced ejection fraction, in general, we start the patient on an AC inhibitor, a beta blocker, a loop diuretic if congestive symptoms are present, and a mineralocorticoid receptor antagonist if not contraindicated. We also discussed that if the patient develops a cough and or angioedema, we need to abandon the AC inhibitor and replace it with an ARB instead. We also discussed that if the patient remains symptomatic in spite of treatment with these drugs at optimal doses and for sufficient duration of time, then it's probably appropriate that we start considering the addition of digoxin to these drugs. Now, whenever we begin a discussion on digoxin, we tend to encounter certain similar sounding terms, like, for example, digitoxin, digitalis, and the enigmatic term cardiac glycoside. Now, right off the bat, I think it's worth emphasizing that digitalis and cardiac glycoside mean one and the same thing. Now, it's worth clarifying the term cardioactive steroid, because if we are clear with this term, it helps us to understand better the differences between digoxin, digitoxin, digitalis, and so on. So what are cardioactive steroids? Well, these are naturally occurring compounds. They are seen in various plant and animal species, and all cardioactive steroids exert positive inotropic effects on the heart. They increase cardiac contractility. Now, being steroids, they have the steroid nucleus, the cyclopentanoperhydrophenanthrene ring. Now, let's take the steroid ring and let's do some manipulations to this ring and convert it to a cardioactive steroid. So, in addition to certain minor changes, if we were to add an unsaturated lactone ring at position R4, we would be converting this steroid nucleus to a cardioactive steroid. In addition, if we were to add a sugar moiety at the R1 position, we would get a cardiac glycoside, and any drug with this particular structure would be said to belong to the Digitalis group of drugs. Now, the three most commonly mentioned cardiac glycosides in medical literature include digoxin, digitoxin, and warbane, which is also called strofanthin G. Warbane is used mostly for research purposes. Digitoxin is almost never used, and therefore by far the most commonly used cardiac glycoside in clinical practice would be digoxin. So digoxin and related compounds are cardiac glycosides. They are said to belong to the Digitalis group of drugs, and they are all cardioactive steroids and therefore have positive inotropic effects. Now, if we were to consider the positive inotropic agents, they successfully increase the cardiac output, and therefore they exert acute symptomatic benefit in heart failure. However, this benefit comes at a price. Almost all positive inotropic agents cause tachycardia, or an increase in the heart rate, and an increase in myocardial oxygen consumption, and therefore almost all positive inotropic agents reduce life expectancy. Due to this reason, almost all positive inotropic agents are indicated only for the short-term therapy in life-threatening acute decompensated heart failure. These are drugs which are used in intensive care. Cardiac glycosides are, however, a class of positive inotropic drug which, when used appropriately, alleviates symptoms without reducing life expectancy. It is therefore the only class of positive inotropic drug which is indicated for the long-term treatment of chronic heart failure. Now, if we were to classify positive inotropic agents into those which are used in acute decompensated heart failure and those used in chronic heart failure, we would see that there's just one entry among the drugs used in chronic heart failure, and that would be the cardiac glycosides, the most important example of which would be digoxin. There's a whole bunch of other positive inotropic agents used in acute decompensated heart failure, and we will discuss them when we discuss about acute decompensated heart failure. So when given long-term in chronic heart failure, digoxin has been shown to reduce the heart failure associated hospitalization, the rate of heart failure associated hospitalization, and digoxin does this without increasing the mortality rate. It begs the question, how does a positive inotropic drug like digoxin fail to increase the mortality rate when administered long-term in patients with chronic heart failure with reduced ejection fraction? Well, being a positive inotropic drug, digoxin increases the contractility. And when it does so, the cardiac output increases. When the cardiac output rises, there is no longer any reason for the SNS and the RAS to remain activated, and therefore there is a fall in the activity of the SNS and the RAS, and this results in vasodilatation. Now, in the previous videos, we did discuss that vasodilatation would normally cause a fall in the blood pressure, which is detected by the baroreceptors in the aortic arch and the carotid sinus. This would immediately alert the vasomotor center in the brain, and the vasomotor center in the brain would respond by increasing the activity of the SNS and the RAS. Now, in the case of digoxin, this doesn't happen. Digoxin manages to produce vasodilatation without a reflex activation of the SNS and the RAS. In fact, digoxin has got a vagomimetic effect on the AV node and therefore will reduce the heart rate. Right. So digoxin produces vasodilatation and thereby reduces the preload and afterload, and therefore reduces the diastolic wall stress and systolic wall stresses respectively. And as per the law of Laplace, this would result in a reduction in the radius of the left ventricle. The cut section of the left ventricle tends to return to its normal elliptical shape and tends to return towards the ambit of the Frank-Starling law, causing an increase in cardiac output. Importantly, wall stress happens to be one of the major determinants of myocardial oxygen consumption. And when digoxin reduces the wall stress, it reduces myocardial oxygen consumption as well. Right, so the vasodilatation produced by digoxin does extend to the renal vasculature as well. There is renal vasodilatation leading to increased renal blood flow, an indirect diuretic effect, causing a further reduction in the preload, a further reduction in the radius of the cross-section of the left ventricle. The cross-section of the left ventricle tends to return to its normal elliptical shape, falling under the Frank-Starling law and thereby increasing the cardiac output gradually. Thus, digoxin, unlike other positive inotropic agents, improves cardiac contractility without increasing the heart rate and without increasing myocardial oxygen consumption, and therefore digoxin increases contractility without increasing the mortality rate. Now, the above statements are applicable only when the plasma levels of digoxin fall between certain limits, certain very narrow limits. The plasma concentration of digoxin should be between 0.5 and 0.8 nanograms per ml. Now, anything above 1.2 nanogram per ml would be associated with an increase, a rise in mortality rate. So it's clear that minute variations in the plasma concentration of digoxin can change the effects of digoxin from desirable to highly undesirable. In other words, digoxin has a very narrow therapeutic index. The therapeutic index of digoxin is around 2. This explains why, despite being the cornerstone of heart failure therapy for decades in the recent past, the use of digoxin is constantly declining. Okay, so digoxin has got two important effects. We discussed regarding the positive inotropic effect or at least we introduced a positive inotropic effect, and this would make it useful in the treatment of heart failure. We also discussed that digoxin has got a vagomimetic effect on the atrioventricular node, and this would give it a good use in the treatment of atrial fibrillation, a cardiac arrhythmia. Now let us focus our attention on the positive inotropic effect of digoxin, and let's try to see how digoxin produces an increase in the contractility of the heart. Right, so to understand the positive inotropic effect of digoxin, it's worth investing some time into trying to understand how a cardiac myocyte normally contracts and then relaxes in the absence of digoxin. Once we understand that, we would be able to appreciate the mechanism of digoxin much better. Okay, so let's consider this to be a cardiac myocyte, and these are the contractile proteins. This blue colored protein would be myosin, and the yellow colored protein would be actin. In the relaxed state, the myosin heads, the blue circles, are prevented from interacting with actin by a protein called tropomyosin, represented by the black lines over here. The tropomyosin molecules have got troponin attached to them in the form of, represented in the form of those black circles. So this entire unit would be called a sarcomere, bounded by Z lines on either side. So that's a sarcomere. Now when this cardiac myocyte is stimulated, there are storehouses of calcium in the cytoplasm of the cardiac myocyte. The cytoplasm of the cardiac myocyte is also referred to as the sarcoplasm. So the sarcoplasm contains certain structures known as sarcoplasmic reticulum, represented by the blue colored box, and they are storehouses of calcium. When the cardiac myocyte is stimulated, the sarcoplasmic reticulum releases calcium into the sarcoplasm. Now as you can see, the sarcoplasm is now very rich with calcium. Some of this calcium will bind to the troponin heads, and when this occurs, there is lateral displacement of tropomyosin, as you can see here. So now the myosin heads are free to interact with actin. Now let us see how that interaction occurs. If we look at this particular side of the sarcomere, we can see that the myosin heads are going to interact with actin and drag the actin molecules towards the midline, and in doing so, it will drag the Z line towards the midline. So it will drag the Z line in that particular direction towards the midline, and the net result would look something like this. Similarly, the same thing occurs on the opposite side of the sarcomere. The myosin heads interact with actin and they drag the actin molecules together with the Z line towards the midline, such that the net result would look something like this. So as you can see, the entire length of the sarcomere has reduced considerably. The original position of the Z lines were there, and from those positions the Z lines have come much closer to each other. When this occurs in multiple sarcomeres throughout the cardiac myocyte contracts as a whole. So this is how a cardiac myocyte is going to contract. Now let us assume that this is the cell membrane of a cardiac myocyte. The cell membrane of a cardiac myocyte is also called the sarcolemma. So there's the sarcolemma, and that would be the sarcoplasm, or the cytoplasm of the myocyte. And as you can see, the cytoplasm of the myocyte is rich with calcium. For this particular cardiac myocyte to relax, calcium should be cleared from the sarcoplasm, and there are two ways of doing this. Number one, the calcium can get pumped back into the sarcoplasmic reticulum, and secondly, the calcium can be pumped out of the cell altogether. So there's the sarcoplasmic reticulum full of calcium. Now we need to pump some amount of calcium from the sarcoplasm back into the sarcoplasmic reticulum. We have a pump for that. It's called the calcium ATPase pump. And since the calcium ATPase pump is seen on the sarcoplasmic reticulum, it is called the sarcoplasmic reticulum calcium ATPase, or SERCA for short. SERCA pumps calcium from the sarcoplasm into the sarcoplasmic reticulum, thus clearing the sarcoplasm of some amount of calcium. But as you can see, there is still some calcium left in the sarcoplasm, and that calcium needs to be got rid of. There is a calcium ATPase pump seen on the sarcolemma. It pumps calcium out of the cell, thus reducing the sarcoplasmic calcium further. But as you can see, there is still some calcium left, and that calcium also needs to be pumped out, and this is achieved with the help of a pump known as a sodium calcium exchanger, or the NCX. The NCX pumps calcium out, and in exchange it pumps sodium into the cell. And in these ways the calcium is completely cleared of the cytoplasm. Now there is one more important pump seen on the sarcolemma, and that is the sodium potassium ATPase pump. This is a pump which is seen rather ubiquitously in almost all cells of the human body. Right, so the sodium potassium ATPase pump pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. Yeah, so now since the cardiac myocyte, the sarcoplasm rather, has been cleared completely of calcium, the tropomyosin and troponin heads can now come back to its original position between the myosin heads and actin and prevent their interaction with each other, and therefore the sarcomere returns to its original position, and when the sarcomeres all over the cardiac myocyte return to its original position, the cardiac myocyte relaxes. Right, so we have discussed in great detail regarding how a cardiac myocyte contracts and how it relaxes. We are now in a much better position to understand the mechanism of action of digoxin as a positive inotropic agent. We are familiar with this diagram. Now, if we take a look at the sodium potassium ATPase pump, we can see that the intracellular portion has got an alpha and beta subunit. We can see that the alpha subunit has got attached to it a beta aspartate unit, a beta aspartate moiety. Now when this beta aspartate moiety is phosphorylated, digoxin tends to bind very strongly to the sodium potassium ATPase pump and inhibits its activity. The sodium potassium ATPase pump now fails to pump potassium into the cell and fails to pump sodium out of the cell. The result is an increase in intracellular levels of sodium. Now when the intracellular levels of sodium rise, the sodium calcium exchanger tends to work less, because if its activity is higher, it's going to increase further the intracellular levels of sodium. So the sodium calcium exchanger reduces its activity, and when it reduces its activity, it pumps less calcium out of the cell, and therefore there is an increase in intracellular levels of calcium. So digoxin inhibits the extracellular portion of the sodium potassium ATPase pump, resulting in an increase in intracellular sodium. The sodium calcium exchanger works less to prevent sodium overload. Less calcium is extruded, and we know that calcium is the ion that determines the force of contraction. More calcium is available to bind to the troponin heads and increases the likelihood of lateral displacement of tropomyosin, and therefore we can expect an increase in the force of contraction. This explains the positive inotropic effect of digoxin, and as we discussed earlier, it causes an enhanced contractility, an increase in the cardiac output, a fall in the SNS and RAS activity, resulting in vasodilatation that does not result in a reflex increase in SNS activity and RAS. There is a reduction in the preload and afterload, reduction in wall stress, reduction in the radius, a reduction in myocardial oxygen consumption, renal vasodilatation, and the consequences which we explained in detail earlier. So that would be the mechanism of action of digoxin as a positive inotropic agent.